This is You Only Know What You Know, a podcast by Compass Health Center about the sometimes messy, always meaningful work of parenting and mental health. I'm Britt Teasdale, a writer, photographer, and parent of 2 young children.
And I'm Beth Hope, a clinician with more than 20 years of experience in youth mental health and a mom of 2 teens. We're here to bring honest conversations, clinical insights, and a little bit of real-life parenting perspective to the table.
Because none of us have it all figured out. We're all just learning as we go, and that's okay. There's a phrase that's often used in the OCD world, accommodation. It can sound clinical or even technical, but what it describes is something so deeply human. A parent watching their child suffer and doing whatever it takes to make that suffering stop. Rearranging the house, answering the same question for the 14th time, waiting at the door until the lock has been checked more than one time. The instinct is love, the desire to protect is real, but that protection can sometimes make OCD symptoms stronger. It's not a reason for guilt, it's a reason for information. And that's exactly what this episode is about.
Our guest today has spent her career working with children, teens, and families navigating OCD, and she brings a depth of clinical expertise that we have been looking forward to sharing with you. She understands not just the child sitting in the therapy room, but everyone else in that household who is quietly holding their breath. Katie, we are so glad you're here. Tell us a little bit about yourself and the work that you do.
Thank you both for having me here. I'm really excited to be doing this with you all. Like you said, my name is Katie Torres. I'm a licensed clinical social worker. I've been in the mental health field for about 16 years now. And I kind of stumbled into working with individuals with obsessive-compulsive disorder during my graduate school internship. You know, it's really not a focus or something that you learn a whole lot about specifically in a master's of social work program. But I loved it so much from day one, just seeing people who were really struggling with OCD and the impact that that had on their lives and their families and how much better they actually got from treatment, that I just never really wanted to do anything else. So I stayed in that world from day one of my first clinical experience ever. And it's really been what I've continued to do for my entire career, is just work with individuals and families who are experiencing OCD and how we can help them feel better.
Katie, what's something that people might not find in your professional bio that you would want people to know about you before we start getting into the topic?
Yeah. Probably just that especially when we think about families and accommodation, maybe just that I'm also a parent. I have 3 little kids, including 8-year-old twins and a 5-year-old daughter. And I have many different roles at this phase in my life, but that's definitely my favorite role. And a lot of what we talk about when I think about OCD treatment even and understanding anxiety and family accommodation, I really try to think about how I can bring that into my role as a mom too.
I love that. So tell us, I think most people know, but there's also a lot of misconceptions out there. So why don't we level set and just start with, what is OCD? Where does it come from? Why do some people have it?
OCD, or obsessive compulsive disorder, is a mental health condition that's really categorized by someone who's experiencing recurrent distressing thoughts. So thoughts that they do not like, right? That they feel like do not fit with them. And when they have those thoughts, they feel either anxious. A lot of times that emotional distress is anxiety, although sometimes people will describe it more, not so much as a feeling of anxiety, but more a feeling of disgust or a feeling of something not just being quite right. So I think that's important to note, because for some people who say like, well, I don't really feel anxiety when I have these thoughts, I feel really, really disgusted, or I just feel really wrong in my body. So we want to make sure we capture those individuals as well. That emotional distress then leads to some type of attempt to relieve that distress, whether it's a physical act you're doing or a mental process you're doing to try to bring that distress down. And it kind of just repeats in this pattern, right? So there's a thought I don't like, distress I feel from that thought, process or act I'm doing to bring that distress down. And it works in the short term. You know, individuals feel relief for a few moments, a few minutes, until the next thought pops up. So it becomes this kind of really problematic cycle that can start to interfere in pretty much every area of someone's life.
Do we know why some people develop OCD and others don't?
Yeah, it's a really good question. And there's, again, a lot that's still unknown about that. We know some things. We know that there's certainly kind of some genetic component that looks at this. And they've done some really interesting studies looking at identical versus fraternal twins. And they've found a higher rate of OCD among identical twins than fraternal. So there's certainly some like gene variants that play into this. And then there's also things that have to do with brain structure and chemistry and imbalances with neurotransmitters like serotonin. And then there's also environmental factors, right? So things that people are exposed to, stressors, life events, and all of those things can influence why maybe someone develops OCD and why someone does not. And I think that can be hard because that means there is not one kind of really clear understanding. And I think sometimes for people who suffer with OCD or for their families, it helps us to know why something is happening. And sometimes I think it can almost lead to this unhelpful search for like why do I experience this and someone else doesn't? And it can feel a little bit like I need that answer in order to move on or to engage in treatment. And so I always really try to help people a little bit if they can untangle from that and to try to have some level of acceptance of I may not understand exactly why. I may know these things contribute, but I can move forward and engage in treatment and start to do some of these things that give me part of my life back, even if I don't have the full understanding of exactly why this is occurring.
Is there a typical age or developmental stage that it begins to show up in people, or can it really come at any point in the lifespan?
Yeah, that's a good question too. I think a lot of individuals start to experience symptoms around that age of like 8 to 12. So in childhood, and then there's again kind of a young adult, kind of 18 to 22-ish range that we can see symptoms start to develop. But even that answer is complicated because a lot of times people are struggling with these symptoms for a very long period of time before they actually get an accurate diagnosis or before they get evidence-based treatment and support for that. But that's generally when we're looking back, that's when symptoms start to kind of show up and present.
And I know we've talked about this in other conversations, Katie, how OCD is really described as one of the most treatable mental health conditions, which is so interesting. And I just was hoping you could kind of dig into that a little bit because OCD really is widely misunderstood as a mental health condition.
Yeah, I think you brought up two really important things that I would want anyone who's struggling with OCD or has a child struggling with OCD to understand is the first point actually being that kind of like you said, Britt, OCD is not it's not a personality quirk. It's not just like, oh, it's this little thing I do. I have to, organize my cookie drawer in this way or my veggie drawer by color. It's not something that people find, fun or cute or easy to manage. It can be really, really debilitating. And people who experience this thing know that, and their family members know that firsthand. So we kind of have to hold that as a really important truth. OCD is a really serious and it can be a debilitating mental health condition. And at the same time, that there is really quality evidence-based treatment that is available. And we do know that it works. We have tons and tons of research studies and randomized controlled trials that show that exposure response prevention with or without medication management is going to be successful for a majority of individuals who tried that, and that they're going to experience significant symptom reduction when they engage in treatment. So both of those things are true. It can be really debilitating, and there is really quality evidence-based treatment available for it.
I think that will be really helpful for people to hear because I know I didn't know that when we first kind of started really digging into what OCD is. And I did not know that it was one of the most highly treatable mental health conditions. Do we want to kind of dive into what OCD can actually look like at home within a family system, like kind of on the day to day? If a parent is unsure about maybe some behavior that they're seeing, can we kind of dig into that a little bit?
It's a good question, Britt, and I promise not all of my answers will be like, and it could be this or it could be that. But you made a great point that this is one of those areas where we want to be really mindful that there is not one specific way that OCD is going to show up for anyone, and that includes children. And so while that cycle that we talked about with OCD, that cycle of a thought, emotional distress, doing something to reduce that emotional distress, that's going to be really consistent with OCD. But the content of what that thought is about or what they're doing to bring down their distress, that can vary so widely for every individual that it can just look really different. And so we always say if you've met one person with OCD, then you've met one person with OCD. So we are not going to make assumptions about, what that looks like for them. What I will say about, younger children is that, for example, what this could look like is that you are noticing your child is starting to engage in a lot more reassurance seeking, right? So they are coming to you and asking more repetitive questions, or there almost feels like they're confessing different thoughts that they're having or things that they did. And they seem like they are really in tune to kind of hearing you say that what they did was okay, or that the thought they're experiencing is okay, that they are safe, that they are a good person, that they don't need to worry about this thing they're bringing to you. So that's one thing that we might see. But on the flip side of that, I think it's also really common that when children start to experience OCD symptoms, the thoughts that they're having feel so misaligned with who they are, that there's a lot of shame around that. And they may be actually scared to even tell their parents the thoughts that they're having. So we may actually see that children start to retreat more and isolate and are less communicative or are spending more time alone or in their room because maybe they're so afraid of the thoughts that they're having that they are concerned about being around their family members or their loved ones. So, just an example of how this same kind of mental health disorder might look two really different ways for a young child based on how they might be responding.
Let's say I'm a parent and my kid is coming to me and consistently seeking reassurance or asking the same questions over and over. What should I do?
I know for me as a parent, if I'm not in the field and I'm not talking about family accommodation and the impact that it has on OCD symptoms, if my child's asking me a question, I'm going to be inclined to answer their question. If they're asking me a question 3 or 4 times, I'm probably going to feel some type of emotion like annoyed or frustrated, but I'm also likely to still answer their question. And so that's a really normal response. I think it's what most parents would do. And when a child is struggling with OCD, unfortunately, it can become this piece that actually perpetuate that OCD cycle. It kind of becomes the part of the cycle that's that ritual or behavioral response that brings kids relief really momentarily for their OCD symptoms, but it actually increases the feeling of, well, next time that thought comes up, I need to make sure I tell mom or dad. That's what's going to keep me safe. So I better make sure I do this again. And so it reinforces that cycle, unfortunately, in a pretty unhelpful way. All that to say, that doesn't mean you don't answer your child's question, but it does mean that you probably want to get curious about if this feels different from your child's kind of baseline functioning. That's something we want to clue into of, oh, this feels different. And maybe I want to talk to a mental health professional or talk to their doctor about some of these new behaviors and things that we're seeing.
So that makes a lot of sense to me. And like you said, easier said than done when it's your own kid. And I think, though, about not just the reassurance seeking or the questions, but sometimes there are these behaviors that kids feel like they need to complete or do before they can move forward. And sometimes they feel harmless in and of themselves. Sometimes they don't. But when you're a parent and you are trying to get out the door to get to work or get your kid to school, or you have other kids and the instinct, like you said, is just to let them do it and move on. And what I hear you saying is in the moment that feels helpful to the kid and helpful to the family system so that it's not impacting everyone else and people can move on with the things they need to do. But really long term, that's maybe exacerbating the situation and it's never going to end without some sort of change in the intervention. Is that right?
Yeah. Yeah, that's exactly right, Beth. And there's so many reasons that those kind of accommodations and systems get put into place. We talked about this, but OCD can really take up, such a presence in the individual's life. It feels like such a strong pull. It is not something that feels easy at all to walk away from when it's like, I need to know that appliance was turned off. Like, it is not just, I can turn around and that thought will fade to the background. Kids really don't believe that. They don't believe that until they're actually doing it and seeing that it's true. And so in the moment, that pull feels so strong, that distress feels so real that, of course, loved ones are inclined to, number one, do what they feel they need to do to bring down their child's distress, right? We always think we're helping. That's why we do those things. And also, there's so many competing interests, especially in the morning before school or at bedtime, when there are real things that have to kind of get done and places that people have to go, that it does become a natural response to say, we're going to do what we need to do to get out the door. And that kind of feeds that exact cycle and pattern of, unfortunately, what the child can take away is, oh, even mom or dad or my loved one or guardian, even they see that this is really dangerous and important because even they went back and checked it 5 times. So they know that either this fear I have could be true because they're engaging in the behavior with me to make sure it doesn't happen. Or even harder is the anxiety I'm feeling. Like, mom and dad know this distress I'm feeling really is dangerous and we need to do something to bring it down. I think that's the message that can inadvertently get sent when we engage in those family accommodations. Like, you can't handle your own feelings of distress. And that's such an important focus that we take in treatment for kids is how do we help them understand that they can handle their own feelings of anxiety without the use of those behaviors to kind of artificially bring it down.
Does OCD often get misdiagnosed as like generalized anxiety, or does that happen sometimes? Because I'm curious about the difference between having an intrusive thought, like, we all have intrusive thoughts sometimes, right? Like, they come in and you're like, "Whoa, what was that?" And then they go, right? But really, like, how do we really know what that difference is? Because I don't want some parents listening to be like, "Oh, I have intrusive thoughts sometimes," and
Yeah.
then they think, maybe I have OCD. So really, how do we kinda break down that difference?
Yeah. Yeah. So one thing that we think about when we think about OCD, or you're making a really great point that we all have thoughts that we feel are intrusive or unwanted. And I have thoughts that fall outside of kind of typical Katie thoughts where I can be like, oh, like what? That's interesting that I would be thinking about that. And if
Mhm.
I don't struggle with OCD, my brain is able to kind of sort those thoughts pretty quickly without me even realizing it, right? It's not a conscious process that my brain can kind of sort it as more of like a garbage thought. I'm not going to do much with that or pay attention to it because it just doesn't align with me. It doesn't feel super important. And so, one of the ways that we try to help kids and families understand what's going on with OCD is that the presence of that thought isn't necessarily what's different when you have OCD. It's more that like your garbage sorter gets turned off. And so, when a child has a thought, like I'm just going to use an example here, like what if I raised my hand in class and said something really inappropriate, right? What if I said a swear word or something that I wouldn't want to say? When they have that thought and they struggle with OCD, instead of the thought being kind of quickly and automatically sorted into the garbage pile and then moving on, there's this like secondary process that happens of thinking about the thought. And well, why would I have that thought? What does it mean that I had that thought? What does that say about me? And also, I better put my hand down right now and make sure that I do not participate, because what if I accidentally said that out loud? And what would that mean about who I am? And so it's the importance that gets paid to that thought, and then the processing and the mental or physical things we do to try make sure that thought doesn't come true. That's really what makes up OCD. So it's all those things that like come up after. And of course, the more we try not to think about anything, the more we're going to think about it. So then it becomes that chain reaction of, "Well, I can't stop thinking about saying something inappropriate in class. And I'm having increased frequency of those thoughts and duration because there's so much power that's in them now."
Yeah, it must be so, like, exhausting. That process must feel really exhausting for a child or whoever is struggling with that kind of cycle. I can imagine must be really tiring, and the shame in that too must feel really exhausting as well.
Exhausting is a really good word that I think a lot of people really resonate with if they experience OCD. Feeling like you're in constant battle with your thoughts, right? Or feeling like you're having to constantly filter what you're thinking or what's going through your head and pay attention to them, which is something that for individuals who don't struggle with OCD in that same way, like we don't have that same kind of process that we have to attend to. So exhausting is a really good word. I also think you mentioned, what can OCD look like instead? What might be we be missing and thinking maybe it's this other thing, but there's so many ways that can show up, right? If a child is really preoccupied with the thoughts they're having and tending to them, that might also look like ADHD, right? Or attention issues that show up in a classroom. The child seems disengaged, or it seems like they're thinking somewhere else or not focused on the task at hand, when that all might be true because what they're focused on is their thought process and the rituals they feel they have to engage in to make those thoughts go away, to keep them at bay, to keep them from coming true. That's going to take a lot of attention and focus away from school, relationships, other things that are important to them.
When we're talking about OCD symptoms, thoughts, actions, behaviors, but for the one experiencing them, that's who they are, right? I think a lot of these kids and teens and adults who struggle with this, it's very hard to defuse from that. And so it's not, I'm having this thought, and I know that's part of the intervention. If we're treating OCD, it's, I'm bad. I'm having these inappropriate thoughts. Something is wrong with me. It's not, oh, I have to tend to my thoughts right now. It's these thoughts are who I am. And that's really shameful. Or what does that mean? And if it's coming at, 10 years old, 12 years old, that's the time when they're supposed to be figuring out who they are and identity is developed. And so that can feel really tricky and overwhelming. I think the other piece, and Britt, I know you asked sort of the diagnostic question, like, how do we know what this is? I wanted to ask about comorbidities also. And I'm sure, again, like you said, you've met one person with OCD, you've met one person with OCD. I think it would be helpful to talk a little bit about some of the different types of OCD, and also, and maybe it doesn't matter because we're going to intervene in some of the same ways regardless, but You mentioned ADHD. I know there's a lot of overlap with certain symptoms of some people who are on the autism spectrum. How do we know what we're treating and what typically shows up together with OCD?
Yeah. Yeah, it's a really good question, and everything you said rings really true that there is a high rate of comorbidity for individuals with OCD with things like mood disorders. So depression, I think there's also a real relationship there that, like you shared, Beth, if especially if I don't have kind of an understanding and accurate diagnosis, there's these formative years of, oh, like I'm having these thoughts. What does that mean about me? I'm different. I'm bad in some way because of the thoughts I'm having. That it also makes sense that there's kind of a correlation with mood disorders, depressive symptoms. There's also a high rate of comorbidity with ADHD and also with autism.
I asked about autism because I'm obsessed with Love on the Spectrum.
Me too.
And a lot of the people who are on that show also talk about having OCD.
Yeah.
Similarly, I watch Baylan Out Loud. I love her. She has Tourette syndrome. She also has OCD.
Yeah.
There are so many comorbidities and also overlapping and confusing symptoms. How important is it that we get to a clear diagnostic picture? Are we treating it differently if their symptoms are the same? Tell me a little bit more about that.
Yeah, I think that you're getting at something that's really important, which is that evidence-based treatment for OCD is exposure response prevention. And while exposure response prevention is a kind of under the umbrella of cognitive behavioral therapy, it is a specialized treatment indicated for OCD and anxiety disorders. So it is different than the treatment we would use, for example, for someone who is just struggling with a lot of worry or more generalized anxiety presentation, or someone who's struggling with depression or ADHD. So it is a really specific intervention that we want to use when people are struggling with OCD. And so that's why accurate diagnosis and understanding of what's going on is so important, because OCD can look like so many other things. And there can be a lot of comorbidity where I'm struggling with OCD and I'm experiencing ADHD. So we want to understand, how do we use ERP really specifically to target OCD symptoms for people?
Yeah, I think that that is such a great response. It makes me think of when we're talking about comorbidities and just what can be happening simultaneously. It's a pretty dark show, but a show that has been on my mind that a lot of people are talking about right now is Euphoria. And it just makes me think of the main character in that show, Rue. It's a wild show and there's a lot going on, but at its core, it's really about mental health and substance use, and she's struggling with that. And I remember, I think it's in one of the first couple of episodes, they kind of get into how she from a young age was dealing with OCD symptoms, and then she was diagnosed with bipolar, and then she got into substances, and it was painting the picture of how a lot of her mental health struggles, I don't think she received necessarily treatment for, and they kind of turned into performing her own coping mechanisms that were unhealthy and all of that. And so I'm curious what can happen when it is misdiagnosed or an individual doesn't receive treatment, and how sometimes we can develop coping mechanisms that aren't healthy.
Yeah. I watched episode 1 of season 3, right? Last night. And it was, oh, Rue is still, she's still out there just trying to get by much after high school now, but it's a really good show. And I think it's a great point about what can happen for, really for any mental health disorder when there isn't appropriate treatment or appropriate understanding, and just the ways in which, especially when we think about OCD and we think about the messages that might be being sent to ourselves when we have these thoughts that don't line up with who we are, that of course that leaves room for a lot of maladaptive coping to come in, right? So things like substance use to try to mask maybe some of the distress that I'm feeling. My sense of self is really impacted by the symptoms I'm having. And again, I think all of this can be really helpfully mitigated by appropriate psychoeducation and diagnosis and treatment. But when that's not there, this isn't to be scary. Of course, we see things like increased rates of substance use or things like self-injury and just other coping mechanisms that people are using to try to quiet some of that noise that they're feeling inside their head, that they really don't have another tool or way of understanding of how to deal with that. I think the other thing too that we see with OCD that kind of goes untreated is that you can just see individuals' lives start to feel really, really boxed in, like just really limited by some of these rules or rituals that OCD puts in place, that things can just start to feel really small and really limited ability to feel like I can engage in, my work, my school, my relationships fully because of the messages OCD is sending me about what you need to do and what you need to make sure of and when you can and when you cannot, that it could just feel so, so limiting.
Yeah, there's that scene in the first season where she's like really young, like 5 or 6, and sitting at the table and she's counting the tiles and she's getting super distressed because she keeps having to like start over.
Yeah.
Is that like an accurate depiction of what a child with OCD in that capacity could be struggling with? Like I'm curious, like did they do a good job with that?
Yeah, I think so. I think it's absolutely can be an accurate depiction of what that can look like. And she's such a skilled actress. So when you think about like the intensity of some of that, I think that matches more closely with what someone with OCD might experience. It's not just something I can step away from. I feel really locked into needing to ensure that I get this right. And there might not be an objective what is right. It might be more tied to I need to count these tiles until like emotionally that feels a certain way in my mind, in my body. And so for Rue or for anyone struggling with OCD, that might mean 2 times of counting, right now, but a day later, it might mean I have to count that 17 times until I achieve that same kind of subjective feeling of rightness. And so that can feel really challenging too, because it's like, it's a moving target. I think about too that one of the ways that when we think about accommodation, I'm not remembering who else was in that scene, but that's one of the ways that I think accommodation can start to really come into the picture when we think about young kids, their family members who are there, and we think about the way a sibling might have to feel like they need to participate or not participate in that moment. But I think it would be really common, for example, if a child's struggling with their OCD ritual and a sibling is sitting at the dinner table with them as they're doing that counting, it'd be really common for the child to tell the sibling, don't talk, don't say anything. I'm trying to get this right, right? And so just the way that that impacts not just that person, but their whole family system, asking them to maybe stop the conversation, pause until they can get the ritual right and the feeling that they're kind of seeking.
Yeah, I think that that's such a great point, and maybe we should kind of dive in a little bit to the siblings' experience a little bit more, growing up alongside a child with OCD, how that can look.
Yeah, I think it can be really hard for siblings. One of the biggest impacts is they're really impacted by number one, seeing their loved one struggle in this way, right? OCD is so challenging. And when you're a young person, seeing someone you love, your brother, your sister, struggle in this way can be a really challenging emotional experience in and of itself. And then there's the reality that a lot of times OCD does seep into those family dynamics and household norms and rules. And so it's certainly not uncommon that a sibling is maybe participating in some of the rituals or rules that the individual with OCD has for how they behave, that gets trickled down to the sibling too, and that they feel compelled to engage in those same processes, whether it's checking something or not speaking when someone's doing a ritual or washing in a certain way, whatever it might be. I think it's pretty common and normal that they get pulled into those because they too don't want to cause distress. They want to see their sibling feeling okay, and it feels like this is a way I can support in doing that. So those are some of the things we kind of have to think about in treatment too, is not just working with caregivers, but also making sure that trickles down to the other siblings of how do we give them permission and encouragement to start challenging some of these OCD rules and showing up in a supportive way versus an accommodating OCD way for their loved one. Thinking about for parents, like I know I parent my children somewhat differently because they are different children who have different needs and different things that come up. And so the way I respond to one of them may be different in some ways than the way I respond to another. And I think that can offer a helpful understanding of how for caregivers and loved ones, how accommodations can so easily come into play with OCD, because it may be that for one child, something that you were just doing as kind of a family routine or just a normalized behavior was totally received just as it was, right? Whereas for another child who has OCD, doing that same kind of behavior could become like a ritual or a compulsion. I think about if I always tell my child when I drop them off at school, I'll see you at the end of the day at 2:30. And one of my children is like, okay, cool. And walks into the school building. And then a sibling of theirs, when I do that at school drop off, their response is like, do you promise you're going to come at 2:30? And I'm like, yeah, I'm promising I'm going to come at 2:30 and pick you up. Are you sure you're going to come at 2:30? Yes, I'm sure. And then like is asking the teacher maybe to email me midday to confirm that mom is picking me up at 2:30, where like that same very innocent, just like normalized behavior can become part of a ritual or compulsive process for a child who struggles with OCD. But it would be really easy without even realizing it for me to go into that pattern of course, I'm going to tell them 4 times and I'm going to email the teacher back so they can see my email response that yes, I'm coming at 2:30, because it wasn't something that I had to think about with another child or a sibling. And so I just want to share that because in OCD treatment, we want to be really mindful that as we're talking about family accommodations with parents and caregivers, that there is not a lens of any kind of guilt or shame about some of the things that are in place at home that are perpetuating OCD symptoms. We have to name that and provide that information because it is so important in the effectiveness of treatment that we pull some of those things back and start to respond differently. I just want to normalize how common it is. They did a study of children with OCD, and in 90% or more, there was family accommodation present in the home. And that's just because it's such a normalized and biological instinct that we want to do. I know that doesn't answer your question about siblings, but I just wanted to name how this might look different child to child and what might show up for a child who has OCD in the way that that accommodation really takes on a different lens or meaning.
I think that makes a lot of sense. And just like you mentioned, we need to parent each child differently because each child is different. Each parent has a different parenting style. And sometimes there's extended family or step parents involved in the child. How important is it in treating OCD within the family to get parents aligned on the level of reassurance or accommodation or how we're responding to certain things? I know that's really tricky and we can't ask everyone to be exactly the same. How do we start to identify some of that and help parents get on the same page? And how important is it that they're approaching things similarly when this comes up?
I always feel like it's more important not even to necessarily be aligned, but just to be communicating with one another and to have kind of a shared understanding of each other's perspectives. And sometimes I think that gets lost in the trying for total alignment of we are never going to answer this question more than one time, right? I, I think that's great and that's important, but I guess I don't think that's as realistic as like, can you and I have the same shared perspective that we are aligned that our child is experiencing OCD. We are aligned that we want to help them get support and treatment for this. We are aligned that in general, us accommodating or providing reassurance kind of perpetuates that OCD cycle for them, and that we want to work together to support them differently and to show up in a different way. And so to me, I found that it goes better when those conversations can be around that. And sometimes then, of course, we have to get into the nitty gritty details of like, what is that actually going to look like in practice? But if we haven't had that conversation first, I think it can be harder for two parents who may just have different tolerance themselves for emotional distress, anxiety in their children, to get to that same point of, yes, we're going to stop answering the question multiple times. That's a great end goal, but I think all those other things have to kind of happen and be communicated first.
I imagine how we respond either to the child themselves who's experiencing the OCD or the siblings is really going to depend on the age or developmental level and insight of the child, because why we're responding differently between children or helping a sibling understand what's going on with their sibling. I assume it depends on how old that sibling or that child is and what they can understand and what those relationships look like. Yes.
Yeah, absolutely. And I think that's bringing up something too that is also really important if we're starting treatment and maybe part of that treatment is decreasing the family accommodations. That's something we're talking about with the child and providing that kind of age appropriate education around why are we going to be responding differently? Because I think without that context and understanding, it can feel the opposite of what the intention is, which it can feel like punitive, and that where is this comfort that I was getting, even if it was very short term and very kind of secular, where is this now? And so we have to make sure we are setting the stage for what we're going to be doing and why. And then the other thing we have to really ensure is that as we're decreasing the accommodations for OCD in the household, we're also like increasing or at least maintaining the level of support, right? So how do I show up for my child in a way that feels supportive and validating without making space for the kind of really slippery OCD things that try to get in there?
Well, and I think, yes, increasing support for the child and the siblings, but also for the parents. I mean, what we're talking about in terms of not accommodating or not allowing a child to follow through on certain behaviors or rituals, basically what we're saying is we're going to make them sit in that distress. We know how uncomfortable that is, which means we as parents are watching that and feeling that. How can we support parents? Because that is really hard to do. And how can we help parents support one another? Um, Watching your kids struggle and really suffer. And you're the one, not who's causing it, but who is preventing them from being able to access immediately what will make them feel better.
Yeah. I think that's the hardest thing, right? Because that's such a real feeling that every parent has. And it brings us back to the whole idea of why accommodations usually are so present in the first place is like that's a biological instinct to try to protect your loved one from feeling distress or discomfort. So I think parent support is such an important piece of this. How can caregivers support one another? How can they seek support for themselves even outside of one another? Because let's be honest, a lot of times when the throes of OCD are present in a household, there is tension in that household. And so sometimes that does mean like, how can we seek support for ourselves outside of even our home, whether that's a family member, a friend, a therapist who we can talk to and have kind of that neutral party and just a space to be able to decompress. I think that's really important. And I also think that, the right support in a family therapy or clinical setting will always come back to that reminder that what you're doing is actually helping your child, not just in the moment with their OCD symptoms, but really building life skills that we probably all want our kids to have, but that are really hard to do in the moment, right? Which is, I actually do want my kids to be able to sit with emotional distress and to know that they can handle those feelings and that they don't have to do any kind of ritual or specific behavior or process to bring it down, that they can handle those feelings and see them come up and come down on their own naturally without needing to immediately fix it. That's a really hard thing, but it is something I want for my kids and for kids I work with. And so it's how do I take care of myself or parents take care of themselves in the moment when that's happening? And how do we remind ourselves of the greater kind of goal or good when it feels really, really, really challenging?
I love that. And that's a theme that's come up in all of our episodes. How do we equip our kids, whether they are struggling with a formal diagnosis and symptoms or just with the growing up process, to be able to handle uncertainty and distress and whatever life will inevitably throw at all of us? We keep talking about exposure therapy, exposure and response prevention therapy as being the gold standard. It's what we use at Compass to treat OCD and other things. And I don't know that everyone knows what it is other than maybe the stereotypical, oh, I have arachnophobia, so someone's going to cover me in spiders.
Yeah. Yeah. And I'll talk a little bit more clinically what ERP is. But the other thing I think about with ERP is back to what you shared has come up in all your episodes of what do we want for our kids is I think about ERP as teaching people to have an approach versus avoid mindset, right? So how do I approach things versus avoid them, whether that's things out in the world, you said arachnophobia. So maybe how do I approach spiders in a specific way? A lot of times it's more so just how do I approach my own internal experiences of thoughts or feelings that I find uncomfortable? How do I approach things or events that are out there in the world that I want to do, but that I have a lot of hesitation or anxiety around? And I think that's something that for most of us, we could agree that's something we want for our kids is to be able to learn how to approach versus avoid. And that's really what ERP gets at. Exposure response prevention is all about facing the things that bring up distress or anxiety. That's part one, exposure. And part two, response prevention is at the same time I'm facing those things, how do I also drop the normal safety behaviors or with OCD rituals, those mental or physical processes that give me that illusion of safety, right? And it's really important when we talk about ERP in any setting, that we really focus on it being those two parts and not just one part, because we can talk about exposure, right? And if I'm facing my fears, but I'm consistently doing these safety behaviors in the moment that are telling me, no, you're okay. No, this isn't actually, you don't need to worry about this, or whatever it may be, I'm not really getting at the important learning that ERP focuses on us taking away. And so that's something that I think can be most challenging when we're doing ERP, is helping kids, especially, to understand what are those processes that they do. And sometimes they're really subtle with OCD. A lot of times they're mental processes. They're not physical acts that we can see. It's maybe, anytime I have a scary thought I don't like, I have to think about Bluey or my favorite TV show or whatever it might be until that thought goes away. We can't see someone doing that. And so we have to focus a lot on psychoeducation and insight and awareness building to make sure we understand what are those processes that we're going to ask you to intentionally refrain from doing while you're working through your exposures. When we do that, we do it in a really gradual way. I think a lot of times ERP gets a bad rap that it's really scary or overwhelming. I think, yes, it is uncomfortable. Yes, it can be hard and scary for anyone to think about facing the things they fear, but it's also like such a compassionate treatment, right? Because you have trained professionals and clinicians who are literally kind of walking alongside you as you face those things that you fear. And as you learn that you're actually able to handle those things and you're able to handle your own internal feelings of anxiety. And that is such a gift, right? To be able to feel like, oh, not only can I handle spiders, but I can more importantly handle, the feelings that come up for me, whether it's emotional feelings or physical sensations when I'm around spiders. And that's like the biggest gift we want kids to walk away from with ERP, is that I can handle my experience of anxiety. My anxiety comes up, it reaches a high point when I'm exposed to things that make me anxious. And if I don't do anything to try to get rid of it, it comes down on its own over time. That's something we really have to be intentional about helping people tap into, that anxiety is like any other human emotion. When my kids feel overjoyed on Christmas morning and they're like at a 10 out of 10, like so thrilled, that doesn't last forever. And they don't have to do anything to bring the intensity of that down. It just naturally decreases over time to where they're like happy. And then, later they're irritated or frustrated and overtired and all the other things. They don't stay at that high level of overjoyed forever. And I think that that's one of the big things with anxiety, is that there's a lot of unspoken fear that I will just feel at this high level of anxiety forever and not be able to manage it.
When we're talking about treatment, how do we know, if I'm a parent and I'm exploring options for my child or teen, what the right level of care would be? So when can OCD be managed, say, with an outpatient, like weekly or biweekly therapy session, versus needing something a little bit more intensive, like an intensive outpatient program or PHP, where they're getting that ERP daily when they're in program? How do you kind of suss out the difference there?
I do think it's important, if you're concerned that what you're seeing is OCD, that you see a treatment provider or a therapist who really specializes in treating OCD and who uses evidence-based treatments like exposure response prevention. I think that's going to help have a solid understanding of what they're looking for and the approach that they would use in treatment. And I think from there, hopefully that clinician can help guide you to what they're seeing in their sessions. But I think a lot about frequency of symptoms, intensity of those symptoms, duration, how long are they lasting? If you're starting to see, a shift of these things had been kind of at a baseline level, like they were able to be managed, maybe it was tough at bedtime, to where now it's hard for them to go to school. It's hard for them to get to the activities that they love because of these symptoms. That's probably a good sign that maybe more support like IOP or PHP is needed, where one of the huge benefits is we can really increase the dose of exposure response prevention that we're doing. And we know that's what helps people get better. And so when we're doing more of that, typically we're going to see that people can get better faster.
We talked earlier about how ERP is the gold standard treatment and oftentimes is effective in treating OCD on its own. And sometimes I know medication can play a part. Help us understand the role that medication might play and how it's helpful in treating OCD.
It depends on your comfort level, but there are medications that are very evidence-based, indicated for OCD, and the combination of medication management and ERP often provides a really optimal result for people, and a lot of parents, especially of young children, want to try just ERP first. And we also see really good results and impact from that. And certain medications and SSRIs specifically can help with that kind of chemical imbalance neurotransmitter part where it can sometimes, if a child is really struggling with ERP to engage because of the intensity of their symptoms, sometimes medication can allow for a little bit more room there. It can somewhat quiet the intensity of those thoughts for them to be able to engage in a more effective way.
If a parent is also struggling with OCD symptoms, maybe they've been diagnosed, maybe they haven't, but they're seeing the same symptoms in their child. How often do we see that, and how do we support both the parent and the child who are struggling? What would you say to that parent?
Yeah, it's such a good question. I've seen quite a bit where if a child is in treatment for OCD, there are times where a caregiver will recognize that although they are not diagnosed with OCD and have not had treatment, they can recognize that what's coming up for them and what we're talking about maybe with their child and in family therapy, there's a lot they resonate with there, right? And a lot of times it's, we talked a little bit about kind of different symptom areas of OCD, although we haven't touched too much on that, but we've certainly highlighted that OCD does not show up one different way. It does not show up 20 different ways. And that even if we think about 25 different kind of symptom dimensions of OCD, there's a lot of nuance even within there. And so what I think a lot of times caregivers recognize though is that cycle, right? That compelling need to feel like they have to respond to certain thoughts in a certain way. And I agree with you, Britt, that I think unfortunately a lot of times it does bring up feelings of kind of shame or guilt and worries about did I cause this in some way? And the answer is just a resounding no to that. And I think also what it brings up sometimes is this feeling of, I think we've done better over the last 20 years of there's a lot more awareness around what OCD is. There's a lot more treatment options that are available now that weren't even 20 years ago, and certainly probably not, 30, 40 years ago. And so I think for parents, sometimes it brings up this notion of, I'm glad my child is able to get treatment for this now, today, because they can maybe go back and see the way some of these areas have been impacting them for quite some time in their life. Sometimes it can lead to some really positive looks at, how about I take what my child is doing and apply that idea of kind of increased flexibility to my own life, where maybe I feel compelled to show up or respond in a really specific way. And so I think that can actually be one of the really nice benefits sometimes there's this trickle down effect that goes in different directions.
Yeah. And along those same lines, can OCD completely go away with treatment, or is it something that a person will manage for life?
Yeah.
Or can they, with certain treatment, like we've been talking about ERP, can it completely go away?
If we can have this shift in the relationship with our thoughts, recovery can go far beyond just symptom reduction. So yes, I'm experiencing less of these thoughts. Yes, they feel less intense, and I'm feeling less compelled to engage in my rituals so that I'm engaging in my rituals less. All of those things are very possible with effective OCD treatment. And then beyond that, I think that leads to a much fuller life and more ability to engage in the other areas of life that OCD can really pull you from. So your relationships, the activities, work, school, the things that are important to you. So I think that's a realistic picture of what effective treatment for OCD can look like. And what that means and what we tell our patients, honestly, is that means you got to kind of hold some space and be aware that sometimes it might rear its head at you again, and it might be in a different way. So it might be about different content than what you had experienced before. Maybe I was really focused on contamination and germs, and maybe I've really made a lot of progress in treatment. But then later in life, I start to notice it showing up in this way that's more checking appliances in my home or harm coming to my loved ones. And so a big part of treatment is about understanding how we can generalize these ideas, not just to one specific kind of content area, but to that larger theme of how do I recognize what OCD is saying? How do I identify that for what it is? How do I practice sitting with that and disengaging from what it wants me to do to give me this illusion of control?
I'm curious, since there is so much stigma and misunderstanding about OCD, you and I talked about this previously, and it was really helpful for me to hear. So I was wondering if you could walk us through what a typical day, like a school day, could look like for, say, a teen that's struggling with OCD. And I know there are lots of different presentations of OCD, but just like an example, what that day could look like and then what their day could look like after learning the proper techniques through ERP to reduce their symptoms.
I think it's important to talk about some of the kind of OCD themes that have more of like a taboo feel to them, because I think when we talk about them more, then hopefully parents and probably not children listening to this, but parents can hear some of those ideas and it can be more normalized. And so if we think about a child maybe who has been experiencing OCD and having some intrusive thoughts about, let's say, like harm coming to loved ones, or let's say even them doing something to harm a loved one, which that's a really common symptom presentation for individuals of all ages with OCD, is having these kind of violent intrusive thoughts that go really against their values that they feel really kind of shaken by. So let's say there's a child who wakes up and is going through their normal kind of morning routine, getting dressed, brushing their teeth, and they see their mom walk by the staircase, and just seeing their mom triggers this thought of, what if I were to push my mom down the staircase? And so again, that thought causes immediate distress for them. It produces this emotional response of intense anxiety. And we might see them respond in a couple of different ways, right? One way might be, I'm going to go back to my room. I'm going to move as far away from mom as possible and go back and lock myself in my room because I want to ensure that mom is safe. And if I'm not physically near her, then there's no way I could have this what if moment of doing something horrible like that. That might be one presentation. Another might be that the child feels they need to instantly confess the thought to mom. And so they're engaging in this kind of reassurance seeking, like, I had this thought. What does that mean? Are you sure this is okay? And which could really derail the getting to school process. But then another ritual response might be just this more mental process, right? Where the child has that thought, what if I pushed mom down the stairs? And instead of doing anything outward, they instead just kind of retreat in and start thinking about that again and again. And maybe the compulsion is more to think about, well, how am I feeling about mom right now? Am I mad at mom? Am I having a positive or negative emotional response to mom? And trying to kind of go down the rabbit hole to get some kind of certainty that this is not a thought they would act on, that they did not want this thought. And it's a process that has no end, right? And so we can see where like those mental rituals that carries into the rest of their day, right? It impacts them getting on the school bus and probably not really feeling like they can engage in a conversation with their buddy who's next to them. And it impacts them on the math test that they're trying to take and kind of shift their energy and focus there. And the problem is that whatever, whether they avoided and went to their room or confessed to their parent or did this mental process, it might work short term until they're at lunch and another thought like that or unlike that pops up, right? So did I just nudge that person when I was in the cafeteria line with their tray? Like, was I trying to hurt them? And maybe that leads to this same or similar process of trying to replay the event, trying to get certainty. And so you can see how it can show up in every single aspect of someone's life, even if we can't physically see that it's happening at all.
Are there any other less common, but also common forms of OCD? We talked already about contamination and germs. We've talked a little bit about checking whether it's light switches or turning the oven off. You just talked about intrusive thoughts around harm coming to others or causing harm to others. I know there's a million types, but that you think it would be helpful for parents to know, like, this might be OCD and worth thinking a little bit more about, or maybe that we wouldn't be aware of.
Areas that I see like coming up for especially like children and adolescents a lot is this moral or kind of almost like scrupulosity based OCD. So a lot of moral obsessions about what kind of person am I? Am I a good person? Sometimes that might take more of a religious theme if the individual, practices an identified religion, or sometimes even if they don't practice an identified religion, which is always interesting. And something that I think comes up, we talk about context and the world around us can shape how OCD shows up for people. And so I think just living in the times that we're living in right now, where there is so much divide, I think there's sometimes that OCD can even latch onto that. I've seen more and more children and adolescents just really concerned about, who am I as a person? What if I say or do something inappropriate? What if I were to offend someone in this way? So I think that's a really common way that OCD can show up too. And it falls outside of typical levels of conscientiousness and wanting to be a good person and good friend. It could become really, really debilitating for them and really limiting.
I think all of the things that we've talked about really can apply to people struggling with OCD, whether they're children or adolescents. And I'm wondering if there's anything specific to young adults that we haven't touched on. Some of our listeners are parents of young adults, and oftentimes the young adult relationship with parents, with siblings, where they might even be living is very different from a child or teen. Are there any things that you would want us to think about or that would be helpful that are different when we're talking about a young adult with OCD?
The big thing that comes up for me is that that's such a period of so much other transition. A lot of times they're moving out of the home for the first time or going away to school or maybe getting a job for the first time or not, right? Maybe sometimes OCD is impacted by that. If there's some of those things they're looking to do, sometimes OCD starts to show up because maybe they're trying to do those things that the rest of their peers are doing. And this is the first time that OCD symptoms are starting to really like impact and limit their ability to do things. So I guess the same things apply, the same treatment approach would apply. The way we think about support and accommodation might look a little bit different when we're thinking about a young adult who's maybe living outside of the home and who we just don't have as much kind of interaction with sometimes or eyes on as to the ways that they might be struggling or experiencing this. So it might require a little bit more of getting a better understanding of how this is showing up for them.
When it comes to OCD, there's that phrase that we have all heard. I'm so OCD. I'm so OCD. I like to keep my house really neat and tidy. I'm so OCD. I love to, whatever it is. I think as you learn more and more about OCD, that phrase can be really frustrating to hear and feel really stigmatizing. If someone who is struggling with OCD or has a child who is struggling with OCD hears that, like someone says it in passing, they're not meaning to be inconsiderate or cruel in any way, but it's just like a phrase that I feel like is part of the vocabulary in a lot of ways. How can we kind of respond to those stigmatizing phrases that we hear kind of just in the day to day? How do you respond to that type of language when you hear it?
Yeah, that's a great point. And I think there's like almost two prongs to that too, right? Because that kind of language can be so invalidating for someone who feels really tortured by their OCD symptoms. But then I think the other prong of why that's so problematic is because I think it really delays people seeking access to effective treatment, right? When we normalize OCD as yes, a personality quirk, a way that I like to have things organized. It paints the picture of something that it's really not, but it also may inadvertently send a message to families or kids or guardians, parents, loved ones that this is just me. This is just a little thing about who I am, not that this is something that can really impact every area of my life, be really debilitating, and that I can get support for. So I think it's really problematic. And I think probably the only way I know how to respond if I hear language like that from, loved ones, friends, people who are not in the field, but are just in my life, probably the best way that I can respond is just by showing them compassion, but then also offering more understanding and information about what OCD actually is and just kind of bringing it back to like, oh, this is what I work with. This is what I do. And it looks a lot more like this and a lot less like that. And it really is something that requires more thought and attention to the way that we talk about things, like so many things. And most of the time, I find when people are saying that, it is with no ill intent and it is just they only know what they know.
I have a question. It might be too far off base, but I was curious because I've come across this just in research and all of that, that there is postpartum OCD, and we're talking to parents, right? So I'm just curious your experience in postpartum OCD, and if there's anything regarding that you would want to speak to today. Is it strictly a hormonal kind of response? What does that entail? If you're able to speak to it, I'm curious.
Some of that might be the hormonal chemical imbalance, but the other part is just like the environmental shift of now I'm having this whole new experience and this human life that I'm now responsible for. It is very common that we see OCD develop or show up in different ways that hadn't been present before having a child. So a lot of that can look like, themes around the safety and security of their baby or around themselves as a mother, obsessive doubt about, if they're going to be safe with the child, if they're doing a good enough job. So that's a really real concern and something that I think we could do even more to improve kind of our own screening and understanding and support for new mothers around that. And then I also think we have to name that there's a societal piece of like, sometimes I feel like we are trying to give new mothers to produce OCD in some ways. And then with the amount of information that is out there and the amount of like, you better do this during pregnancy and you better not eat that. And some of it is so conflicting and some of it is so rigid and over the top. I think that in some ways, like it's a perfect storm for a new mother who is maybe already predisposed to anxiety or some of those things. And then that information overload during pregnancy, especially and early motherhood, it's like, oh man, sometimes you wonder like, yeah, how does that not happen for all new moms with just the pressure and the information that they are under? Dads too, all parents.
100%. I mean, it is what could be more high stakes than, and especially for a first time parent, although I know this can happen, whether it's your first child or not, you are not responsible for another human being. And we are just bombarded with, there is only one right way to do this. Here are all of the wrong ways to do this. To your point, it's often really conflicting information. You need these products. You can't use these products. And God, I mean, we are creating so much anxiety. And if you are someone who's predisposed to anxiety or has OCD, and maybe that's a time that it crops up again in a different way, it's really scary. And I think the big takeaway here is there is help.
Yeah.
There are supports. People are not alone. And I think whether it's a therapist, a primary care physician, some sort of first step toward this doesn't feel good. And that's really hard in the moment when it's your own thoughts that you're having that are maybe being reinforced by our culture or what we're seeing all the time. That can be really hard to untangle when you're in it. If you think about maybe some key takeaways for a parent who, whether they know their child is struggling significantly with OCD or they're starting to have concerns about some behaviors or worries or things that they're seeing in their child, what are some key pieces of advice or takeaways that you would want someone to walk away with?
Yeah. I think the biggest thing I would say is if you are starting to notice that, to just proceed with curiosity, right? And to try to gain a better understanding of, yes, what you might be seeing from your child and curiosity about your own response too. So am I responding in a way that the primary goal is just to reduce their distress in this moment? And if so, does it feel like that's helpful? Does it feel like that might be perpetuating some of this? But I would couple that curiosity with just a lot of compassion for yourself, a lot of compassion for your child, with the reminder that you're the best parent for your unique child. There's no one better for them. And so it is not going to be perfect. I think OCD is one of those things that it brings up an emotional response for the people around the person who is suffering with OCD. So give yourself a lot of grace and a lot of room with that. We talk about progress over perfection a lot in OCD treatment. And so that same idea applies for loved ones and caregivers as they're supporting kids through this.
That reminds me of what you said earlier about, wanting to send the message to kids and people who are struggling with OCD to approach versus avoid. And it sounds like that is what that's the challenge for parents who also are parenting through OCD or any mental health or any challenge with their kids is it's hard, but we also have to approach versus avoid. And a big part of that is getting help.
Yeah. Yeah. And also just parenting in general, right? Like the progress over perfection. As parents, we can get so attached to this idea of being the perfect parent and whatever that looks like for you. And that can really get in the way of our own mental health a lot of the time. So I'm going to take that with me today, progress over perfection as a parent. I think that that's so important. Katie, what keeps you really passionate? Because we can just hearing you speak, you are so passionate about what you do, and it's wonderful to hear you speak on this. What keeps you so passionate about this work and about working with families with OCD?
Yeah, I think just the knowledge and the notion that treatment really works. And I always come back to a young girl at the time who I worked with early on in my career who had really debilitating OCD. And it came on pretty suddenly, really strong contamination concerns to where every area of her life was impacted. Difficulty dressing and going to school, difficulty getting to soccer and to the play that she was in. And it was taking a toll on her life. And I think back to the early days of being a young therapist and treating this girl and just thinking like, how can I support her? The family was really in disarray because this was new and it felt really different from anything they had experienced before. And long story short, that girl, she showed up to treatment every day with her family in just an energy and a commitment that I couldn't imagine from anyone, but from this 10-year-old. She was willing to do hard things. She was willing to be brave every day and sit with all this distress and discomfort. And her mom was really willing to say, I'm going to try to do this differently too, because I really want this to last. And it was such a formative experience for me as a young therapist. And I'm still in communication with the girl and her parents today. And she's a nurse. She's an OB nurse, which is like such an interesting, piece of like, there were really strong contamination concerns. And she's just this, amazing young adult who knows that she has OCD and is able to hold space for that and live the life fully that she wants for herself. That brings me like so much renewed commitment every day, that and many stories like it, of individuals who are really brave and work through treatment and just experience a lot of success. So it's a real privilege to be able to walk along people alongside that journey. And so I just love what I do.
Thank you so much. It was such a treat to be able to discuss this with you. So thank you so much for taking the time to be here. And I think being brave is a key takeaway as well. I love that. So thank you.
Thank you both so much for having me. It was a real privilege to be able to talk with you both today.
If there is one thing we hope you take from this conversation, it's that the instinct to protect your child from distress is so normal. It is one of the most human things about being a parent. Katie said it so clearly today. Accommodation comes from love. It can also keep OCD symptoms in the driver's seat.
The other thing that has stayed with us is how treatable OCD really is. So many families spend years thinking this is just who their child is, or that this is something they have to manage forever on their own. It isn't. ERP works. Your child can get their life back. Families can and do get their lives back. That feels like a really important message to send people home with.
If you're noticing something in your child, repeated questions, rituals you're working around, a kid who seems weighed down by their own thoughts, let curiosity be the first step. Not panic, not guilt, curiosity. Then you can take that curiosity to a clinician or professional who specializes in OCD.
Remember to practice progress over perfection for your kid, for yourself, for your whole family. That's what we're taking with us this week.
If today's conversation resonated with you, share it with someone who might need to hear it. And subscribe to You Only Know What You Know wherever you listen to your podcasts. It helps more parents and caregivers find us.
You can also follow us at Compass Health Center on social. We would love to hear from you. Send us a message or drop a comment and let us know what topics you're interested in. You're not alone in this. Thank you for being here, and we'll see you next time.